My name is Thomas Penzel. I'm the scientific chair of the Sleep Medicine Center at Charité University Hospital, and I work in sleep medicine for many years. My main subject in sleep medicine is to look for sleep apnea and new methods to diagnose sleep apnea.
Can you explain in a simple way what sleep apnea is? As far as I know, it's a very complex disease, and there are many different personas in the science language, different phenotypes. Could you also tell us a little bit about these personas?
Sleep apnea is a very common disorder. Sleep apnea is defined as respiratory cessations, so no breathing for at least 10 seconds. And this happens during the night, during sleep, and it may happen several hundred times per night. So typically in a patient with severe sleep apnea, 300 breathing pauses in the night. But sleep apnea often is not so severe, and therefore we have severity criteria. Everybody has some breathing stops during the night, but typically when dreaming. So a small number of breathing pauses is normal, and therefore we count the number of apnea events per hour of sleep. We say if there are 5 or less apnea events per hour of sleep, this is normal. 5 to 15 breathing pauses per hour of sleep, we say this is a mild form of sleep apnea. If there are 15 to 30 apnea events, we say this is moderate sleep apnea, and if there are more than 30 apnea events, then this is severe sleep apnea. Severe sleep apnea may cause arterial hypertension and is a proven risk factor for myocardial infarction and for stroke. So this is a severe health risk. Therefore, we need to treat it. In order to find sleep apnea, one needs to record whether a person is asleep or awake, because it only happens during sleep. One needs to record whether the sleep is still fulfilling its function of deep sleep and dream sleep, or typically in a patient with sleep apnea, this is lost. So people feel very tired during daytime, and one needs to record the respiration in order to see whether a person is trying to breathe. The disorder is called obstructive sleep apnea because the loss of breathing is caused by a collapse of the upper airways. Typically, we breathe in order to have an exchange of oxygen and CO2. So we inhale oxygen and exhale CO2. And during sleep, this breathing can be less intense because we are not working and consuming so much oxygen. But in these patients, when they fall asleep, then there's a collapse of the upper airways and no air comes in and no CO2. So this is the problem. This is the disorder. There may be different reasons for this obstruction of the upper airways. This is what we call phenotypes. One phenotype is that people have, by genetics, by nature, a short chin. And the short chin makes a small size of the upper airways, and then it is easy for the upper airways to collapse. So that's one phenotype. Another phenotype is when breathing gets slower during the night and oxygen drops normally, which is quite normal, then the patient, the subject, does not respond to the lowering of oxygen very good, because of course, if oxygen gets lower, one should increase breathing. And if there's not such a reaction, that is another phenotype. It is a low response to chemoreceptor drive. Then there's another phenotype where oxygen gets low, but somehow their muscles, they do not react adequately. So the muscle strength of the breathing muscles is not strong enough. That's muscle fatigue, another phenotype. And then we have another phenotype. We have altogether 4 phenotypes at the moment. The 4th phenotype is that the wake up, the arousal threshold may not be sensitive enough. So if oxygen drops, in order to breathe again, the brain center for respiration needs to coordinate the breathing. So it needs to open the upper airways. This is a muscle in the human. It's not stiff, but it is a muscle which we control for breathing and for speaking. And if this respiratory center is not activated enough, we have a kind of arousal weakness. So this is the 4th phenotype. So until now, we know 4 different ways how to come to the disorder of obstructive sleep apnea.
Is it also important to identify this reason? Or someone just have it or not have it, and the therapy is always the same for everybody? Or is it important to identify this phenotype?
Until now, it is the treatment is CPAP. So
for all of them.
Standard treatment is CPAP, which opens the upper airways. This works for all phenotypes. But for some phenotypes, this mask needs to be taken every night. It is like glasses. If you use the mask, the airways are open and it's a perfect treatment. But to use the mask every night is not so nice for many people. Therefore, people often don't like to use it. And therefore, other ways of treatment were developed. One type of treatment is a mandibular advancement device, we call it. It's you put it in your mouth and it's like this bruxism kind of device you put, and it puts forward the jaw in order to open the upper airways. This is good for some phenotypes. It is good for the phenotype with a small jaw. So, and then there is another type of treatment, which is a stimulator. It stimulates the breathing muscles. I told you about this weakness of breathing muscles. So this is a treatment predominantly be used for another phenotype. And now very lately, there are new drugs which also have effect on sleep apnea. So they may have an effect on the chemoreceptors. So we assume that the new therapeutic possibilities, they are more specific to some phenotypes. Until now, the overall treatment, which works in everyone, is CPAP, but the new treatments may be more specific for some specific phenotypes.
Is there any way to prevent this disease? Can we do anything about it?
One can try to have good training, so in order not to get obese. Obesity is a risk factor, high blood pressure is a risk factor, loss of movement, so all the usual things which are recommended by any doctor to any patient. So
basically,
that can have
healthy lifestyle.
Then one has less sleep apnea, but much of it is just genetic predisposition. So with that, one cannot do much.
There are more and more diagnostic mobile apps coming, for example, for skin problems detection, skin cancer, and so on. Is there any potential that we will be able to diagnose sleep apnea with mobile phones in the future?
Yes, we have done a clinical trial with a mobile phone with a French app, which can diagnose sleep apnea. We are also currently doing another study with a company from England, which uses snoring and sound analysis in order to diagnose sleep apnea. So I think that new smartphone-based devices can diagnose to a certain degree. There are some forms of sleep apnea which are more complicated and for which this kind of simple diagnosis does not work. This is not the problem. The problem is who pays for the diagnosis. Do the insurance, does the healthcare system pay for the app or the diagnosis or not? When we put out diagnostic tools which are easy to use, then we find sleep apnea in 40% of all people.
40%?
40. There was a study in Switzerland looking for sleep apnea in people over the age of 40. There they found sleep apnea in 70%. Very few people without sleep apnea. This means a simple diagnostic device would be positive in almost everyone. So this is the problem of the simple devices. Therefore, healthcare systems, they simply do not pay for it, because then they would create everyone a sleep apnea patient. And therefore, there's a big resistance of healthcare systems to pay for it. Sleep apnea is more than just the finding of breathing pauses. It is also suffering from the job. To go to the doctor, only a person will do who really suffers. There's a simple recording in an otherwise healthy person. You will find apneas and they have no relevance.
Yes.
So it's not about finding apneas, it is the whole picture.
Yes.
And therefore, healthcare systems do not pay simple devices, but they pay for devices run by medical people, then they do reimburse it.
I interviewed many people with sleep apnea to really understand this disease, their problem, and these people really suffer, and this is very touching as well. I was very surprised. Some of them who are on the CPAP, on the CPAP therapy, they practice so-called mouth taping. So they have this nose mask and they tape their mouth shut, basically to support the therapy itself. Do you have an opinion on this practice?
Yes. The mouth needs to be shut in order to have this therapy effectively, because the air is blown through the nose and needs to put the upper airways under higher pressure. That's the effect of CPAP, in order to open the upper airways. And then one can breathe on top of this higher pressure level freely through the nose. If the mouth is open, the pressure will immediately go out of the mouth and there's no effect of CPAP. It is very important to have the mouth closed. Normally, when one blows air in the nose, there are reflexes which close the mouth. So normally, normal subjects, they don't need mouth taping because the reflex
closes.
Close the mouth. If the mouth is not closed automatically, something is wrong with the reflexes. This can be because the pressure was not done correctly or the mask was not done correctly. Most of the cases of patients who need mouth taping, it was not a good application of the CPAP mask. And I would recommend the people go to the sleep lab and let the mask and the pressure be adjusted to fit optimal. Then there's no need for mouth taping.
What do you think about mouth taping in general? Because there is this trend that many people who have no sleep apnea do it.
Normally, this is not needed. Normally, well, if the reflexes don't work well, then maybe mouth taping may help, but normally it's not needed. When you sleep, you don't put tapes, or you don't usually
Yes.
you don't need a tape on the eyelids, or you don't need a sleeping goggles. But some
Yes.
people, they always sleep with the sleeping goggles, so it's the same for the mouth. Of course, for some people it may be some help, but it's not the normal way.
Not for everybody. Not yeah.